Hello. I want to start today with something I want you to think about honestly. In the last few years, have you noticed that things feel heavier than they used to? Grocery bags that used to feel manageable now require more effort. Stairs that used to be easy now feel like more of a task. Getting up from the floor, something you may not have thought twice about at 55, now something you plan before you do it. These experiences are real, they are common, and they have a specific biological explanation. My name is Dr. Chen. I am a physician in internal medicine, and today I want to talk about something that affects a very large number of adults over 65 in the United States and worldwide. It is called sarcopenia. It is defined as the progressive loss of muscle mass, strength, and physical function that occurs with age, and it is one of the most important and most under-recognized health issues facing older adults today. Now, I want to be honest about what this video is and what it is not. This is not a video about a supplement that reverses muscle loss or a miracle routine that adds years to your life. This is a real conversation about what the science says, about why this happens, and about what approaches have actually been studied in real clinical trials and found to make a genuine difference. So let us sit down together and go through this properly. Let us begin. First, I want to give you a sense of how common this is, because I think it matters to know that this is not something unusual or something specific to you. Recent epidemiological data indicate that the prevalence of sarcopenia among community-dwelling older adults aged 60 and above ranges from 10 to 27% worldwide. Some estimates put the figure higher, depending on which diagnostic criteria are used and which population is studied. Global prevalence estimates range from 10 to 40% in community-dwelling older adults. Now, why does this matter beyond just feeling weaker? Because sarcopenia is not just about strength. Sarcopenia is associated with increased risks of falls, disability, and all-cause mortality. Those are not minor consequences. Falls, as I have discussed in previous videos, are the leading cause of injury death in adults 65 and older. And sarcopenia is one of the most significant contributors to fall risk because weaker muscles mean a reduced ability to catch yourself when balance is suddenly challenged. Beyond falls, sarcopenia contributes to reduced mobility, difficulty with daily tasks, and a loss of independence that many older adults fear deeply. So understanding what is happening and what can slow it down is genuinely important, not just for quality of life, but for long-term health outcomes. Now, let me explain what actually happens inside the muscle as we age, because understanding the biology is what makes the interventions make sense. Skeletal muscle loss was found to be 3 to 8% every decade after age 40, with accelerated deterioration in muscle strength and mass after 65. So this is not a process that begins at 65. It begins earlier and then accelerates. The question is not whether muscle changes with age. It does. The question is how much and what influences that rate. Now, there are several biological mechanisms behind this, and I want to explain the main ones simply because they point directly toward the interventions that work. The first mechanism is called anabolic resistance. In younger adults, when you eat protein, the amino acids from that protein trigger a process called muscle protein synthesis. Your muscle cells build new protein, new fibers, and repair existing ones. This process is called anabolism, the building up process. Age-related anabolic resistance is a hallmark of sarcopenia. What this means in practice is that in older adults, the same amount of protein produces less muscle protein synthesis than it does in younger people. This signal becomes less efficient, The muscle cells are less responsive, and muscle building happens more slowly for the same nutritional input. This is why protein recommendations for older adults are different from younger adults. Not because the body needs fundamentally different things, but because the system is less efficient and needs a stronger signal to produce the same response. The second mechanism involves motor neurons. Your muscles are controlled by nerve cells called motor neurons. Each motor neuron controls a group of muscle fibers called a motor unit. With age, some motor neurons die, and the muscle fibers they were controlling lose their nerve supply. Some of these orphaned fibers are reinnervated, taken over by neighboring motor neurons. But others are lost entirely, resulting in an actual reduction in the number of functional muscle fibers. This is one reason why muscle loss with age is not fully reversible through exercise. Certain structural changes have occurred that cannot be completely undone. But, and this is important, the rate of this process and the degree of functional impact is significantly influenced by physical activity, particularly resistance training, which helps maintain the muscle fibers that remain and improves the efficiency of the motor units that are working. The third mechanism involves hormonal changes. Several hormones that promote muscle growth and maintenance decline with age. Testosterone in both men and women, though at much higher levels in men, declines with age. Growth hormone declines, and insulin-like growth factor 1, which plays a direct role in muscle protein synthesis, also decreases. These hormonal changes reduce the anabolic environment, the environment that supports muscle building and maintenance, and contribute to the accelerated muscle loss seen after 65. The fourth mechanism is inflammation. Chronic low-grade inflammation, sometimes called inflammaging, is a well-documented feature of aging, and it has a direct negative effect on muscle protein synthesis and a direct positive effect on muscle protein breakdown. In other words, this low-grade inflammatory state is simultaneously slowing down muscle building and speeding up muscle breakdown, making the net effect on muscle mass more negative over time. The fifth mechanism is reduced physical activity. This sounds obvious, but it deserves to be named clearly because it is the most directly modifiable factor. Many older adults become less active for a range of reasons: retirement, pain from arthritis or other conditions, fear of falling, reduced energy, social isolation, and others. And reduced physical activity, particularly reduced resistance exercise, removes the primary stimulus that tells the body to maintain muscle mass. Muscle is metabolically expensive. The body maintains what it uses, and when the demand drops, so does the maintenance. Now, I want to turn to what actually helps, and I want to be specific because the evidence here is genuinely encouraging, and because specific is more useful than general. The first and most well-supported intervention is resistance training. This is the intervention with the strongest and most consistent evidence base for slowing sarcopenia across the widest range of older adult populations. A 2025 scoping review in PMC included 36 studies supporting resistance training programs for reducing sarcopenia risk among healthy older adults. A 2026 meta-analysis of 12 randomized controlled trials involving 518 older women with sarcopenia found that resistance training significantly improved hand grip strength, gait speed, knee extension strength, timed up and go performance, and 30-second chair stand performance. Now, I want to be careful about how I present this, because that same meta-analysis found resistance training had no significant effect on skeletal muscle mass index. This is an honest finding that is worth understanding. Resistance training in older adults more reliably improves muscle strength and physical function. then it increases the raw quantity of muscle mass. In terms of what matters for daily life, that is actually the right priority. Strength and function are what protect you from falls and loss of independence, more than muscle mass as a number. But it tells us that the goal of resistance training in older adults should be framed as maintaining strength and function rather than building bulk, which was never the realistic goal anyway. Now, what does resistance training actually look like? For a person over 65, I want to be specific here, because this is where many people get confused or intimidated. Resistance training does not require a gym. It does not require weights, particularly in the early stages. Resistance training means any exercise that works your muscles against a force. That force can be your own body weight, a resistance band, a light dumbbell, a water bottle, or any other object that provides resistance. Examples of body weight resistance exercises appropriate for many older adults as a starting point include chair-assisted squats, where you slowly lower yourself toward a chair and rise back up. Wall push-ups, where you push against a wall rather than the floor. Calf raises, standing and rising onto the balls of your feet. Step-ups onto a low step, and seated leg extensions, which I described in the chair rising video. The key principles of effective resistance training for older adults are progressive overload, meaning the challenge gradually increases as strength improves. Adequate frequency. Research generally supports at minimum 2 sessions per week, preferably 3 for meaningful muscle maintenance. Full range of motion, moving joints through their full comfortable range rather than partial movements. And controlled speed, particularly on the lowering phase of each movement, which is where much of the training stimulus occurs. Now, I want to address something that is important and that many people wonder about. Is it too late to start if you are already 70 or 75 or 80? The answer, based on the research, is no. It is not too late. The 2026 meta-analysis I mentioned earlier found significant improvements in strength and function in older women with diagnosed sarcopenia from resistance training. These were not people who started training young. These were people with an existing condition who began a structured exercise program and showed measurable improvements. Other studies have shown meaningful responses to resistance training in adults in their 80s and 90s. The magnitude of response may be smaller than in younger adults because of the biological changes I described earlier, but the response is real and it is meaningful in terms of daily life function. Now, the second major intervention is protein intake. And I want to explain this carefully because there is a lot of confusion about protein, and I want to be accurate rather than oversimplified. Older adults require higher quality protein intake of at least 1.2 grams per kilogram of body weight per day to stimulate muscle protein synthesis when combined with resistance training. Now, let me put that in practical terms. If you weigh 70 kilograms, which is roughly 154 pounds, 1.2 grams per kilogram would mean approximately 84 grams of protein per day. As a rough target, if you weigh 60 kilograms, which is roughly 132 pounds, that target would be approximately 72 grams per day. Now, I want to be honest about this number. It is a general research-informed target, not a precise prescription. Individual needs vary based on health status, activity level, and other factors. And for people with kidney disease in particular, higher protein intake may not be appropriate and requires specific guidance from a physician or dietitian. So before significantly changing your protein intake, particularly if you have kidney disease or other chronic conditions, please discuss this with your doctor. That is a non-negotiable caveat. Now, for most healthy older adults without kidney disease, the practical question is, what does adequate protein look like in daily food? Protein sources that are generally appropriate for older adults include lean meats such as chicken and turkey, fish, eggs, dairy products including Greek yogurt and cottage cheese, legumes including lentils and beans, and tofu and other soy-based products. Spreading protein intake across meals, rather than concentrating it in one large meal, appears to be more effective for a muscle protein synthesis. Research suggests that including a meaningful protein source at each of 3 meals per day is more beneficial than eating most of your protein in one sitting. Now, I also want to mention protein supplements because many older adults ask about them. And I want to give an honest answer. Protein supplements, such as whey protein or other protein powders, are not magic. They are a convenient way to increase protein intake. If someone is genuinely unable to meet their protein needs through food alone, they can be a practical addition.
Growing evidence indicates that combining exercise with nutritional supplementation may yield superior outcomes in addressing sarcopenia. However, food first is a reasonable principle. Whole food protein sources provide additional nutrients alongside the protein itself. And many older adults can meet protein needs through food if they are deliberate about including a protein source at each meal. A dietitian can help assess whether supplementation is appropriate for your specific situation. The third intervention worth discussing is vitamin D. Low vitamin D levels are currently regarded as a risk factor for sarcopenia. Vitamin D plays a role in muscle function, and vitamin D deficiency is common in older adults, particularly those with limited sun exposure, which describes many older adults, particularly in northern states, or those who spend most of their time indoors. A simple blood test can determine your vitamin D status, and your doctor can guide you on whether supplementation is appropriate.
And at what level. I want to be careful here. Vitamin D supplementation is not a treatment for sarcopenia on its own. It is a correction of a deficiency that, when present, contributes to poor muscle function. Correcting the deficiency in someone who is deficient removes one obstacle. It does not replace exercise. The fourth consideration is managing other health conditions that may be accelerating muscle loss. Several chronic conditions, including heart failure, chronic kidney disease, diabetes, and chronic obstructive pulmonary disease, are associated with accelerated muscle loss, sometimes called secondary sarcopenia. If you have one or more of these conditions, optimizing their management in partnership with your physician is an important part of managing the muscle loss associated with them. Similarly, some medications, including corticosteroids, when used long-term,
are associated with muscle loss.
If you are on long-term corticosteroids, this is worth discussing with your doctor. In the context of muscle health, not as a reason to stop medication, but as a factor to be aware of and to monitor. Now, I want to talk about how to actually start. If you are currently doing little or no resistance exercise and the idea feels daunting or uncertain, the most appropriate first step for most older adults who are deconditioned or who have significant health conditions is a referral to physical therapy. A physical therapist can assess your current strength and function using standardized tools, design a starting program that is appropriate for your current level. Not too easy to be effective, not too hard to be safe. Teach you the correct technique for each exercise, which matters both for effectiveness and safety. Progress the program over time as your strength improves and identify any pain or limitation.
That needs to be addressed alongside the exercise. Ask your primary care doctor for a physical therapy referral and mention specifically that you are concerned about muscle loss with age and that you would like a structured strengthening program designed for your current level. That framing gives the referral a clear purpose.
Now, for those who are already reasonably active and looking to add resistance training, community options are worth knowing about. Many YMCAs and senior centers offer strength training classes designed for older adults, with instructors experienced in working with this age group. Some programs, like Silver Sneakers, which is available through many Medicare plans, provide access to fitness facilities and classes at no additional cost. It is worth checking whether your Medicare plan includes this benefit if you have not already. Now, let me bring this all together into a clear and practical summary. The first thing to understand
is that muscle loss after 65 is real.
It has specific biological causes, including anabolic resistance, motor neuron loss, hormonal changes, chronic inflammation, and reduced physical activity. And it has real consequences for fall risk, mobility, and independence. The second thing to understand is that the rate of muscle loss is significantly influenced by lifestyle factors, particularly exercise. And it is never too late to benefit from resistance training, even in your 80s. The evidence supports this clearly. The third thing, resistance training, 2 to 3 times per week, progressive, consistent, is the most well-supported intervention for slowing sarcopenia. It more reliably improves strength and function than raw muscle mass, which is the right priority for daily life. The fourth thing, adequate protein intake, spread across 3 meals per day, is an important partner to resistance training.
General research-informed guidance suggests around 1.2 grams per kilogram of body weight per day. But individual needs vary, and anyone with kidney disease should discuss protein intake specifically with their doctor. The fifth thing, vitamin D status is worth checking with a simple blood test and discussing with your doctor if deficiency is present. The sixth thing, if you are currently inactive or deconditioned, a physical therapy referral is the appropriate starting point, rather than guessing at a program independently. The seventh thing, if you have chronic health conditions, managing those conditions well is part of managing muscle health. And any medication changes related to this require your doctor's guidance, not independent decision-making. Now, let me close with something I want you to take away. Muscle loss after 65 is common, but it is not simply something to accept passively. The rate at which it happens and the degree to which it affects your daily life, your ability to carry groceries, climb stairs, rise from a chair, catch yourself when you stumble. These things are influenced meaningfully by what you do consistently. Exercise and adequate protein are not optional extras. For a person over 65 who wants to maintain independence, they are among the most important things. The research is clear, and it is encouraging because it means this is not entirely outside your control. I am Dr. Chen. Thank you for spending this time with me today. If this gave you a clearer picture of what is actually happening in your body and what to do about it, please share this video with someone you care about who may be noticing these same changes and wondering the same things. Leave your questions in the comments. I read them, and I will see you in the next video. Take care of yourself.